So Sue, you wanted to understand a little bit about our new diagrams and how they differ from our old diagrams and how to interpret them.
Please.
Okay. So to begin, the new carrot diagrams are very different from our previous diagrams. As you can tell, they're computer animated, and they're going to be very similar between different physicians. So no longer are we going to have hand scribbles, but everything will be computerized and very reproducible. Second thing, I guess, is that when a person has sequential angiograms from one year to another, we can actually carry on the old pictures and build off of them so that patients don't have the confusion of seeing different numbers and different things. It'll actually be consistent. But really for us, the main benefit of this new diagram is that we're actually able to computerize this all into a database and look back at how we've done certain procedures or how many people have certain types of blockages, certain types of stents. And so we're going to be able to actually analyze what we do at the Heart Center in a way that was never possible before.
Now, is this a national database?
So it is. It's part of the Approach database, which is actually being used from coast to coast. It's being used now in Nova Scotia and Newfoundland, so all of Atlantic provinces, all three cath labs will be using it. And Approach is the general database for all information. This, the CARET, or Coronary Artery Angiographic Reporting System, is specifically for the coronaries and for the cath lab. But again, this picture is the same one they use here as in Edmonton, as in Vancouver, as in Newfoundland. So very similar, and it's also easy to transfer electronically. So we'll be able to send these reports out a much faster way than before.
It looks much more detailed, less cartoonish, and I think it will allow the patient to have a better understanding of what's happening.
Well, in truth, sometimes it may be too much information for the patient. And while it's super efficient for the healthcare user, there are times where there's so much information on this one picture. This truly is worth 1,000 words. We even have a legend along the left-hand side, which explains what some of the diagram is actually showing. For instance, in that legend, you can see we have the first column, or the first line, being lesion. Well, that's obvious. And what we'll have is we'll have little bars to show where the blockages are, and a number indicating how severe that blockage is. Now, our lowest threshold for number is 40. So basically any narrowings less than 40% are just called less than 40. And so it just means mild. But then from that point on, 50, 60, 70% lesions are marked off the way you're used to. But in addition, we also have things like calcium. We can show on that diagram with these little markings which parts of the arteries are very calcified, which is important because the more calcium there is in an artery, the more difficult it is to revascularize, either through angioplasty or surgery. We can show where dissections are, also another little marking here from edge to edge, and we can show where those dissections are, be they a spontaneous dissection or something that was caused by a stent. We can show where areas of the arteries are ectatic or dilated and stretched. Instead of compressing from cholesterol, they actually weaken and enlarge. We obviously can show where stents are. We can show where the arteries, instead of, after stenting or revascularization, instead of remodeling and maybe re-narrowing, actually can enlarge, so positive remodeling. We can show where arteries have slow flow, so TIMI flows refer to how quickly the blood is flowing across a blockage. So if you start seeing dotted lines on this diagram, that means that actually the blood flow is not fast, TIMI 3, which is normal, rapid flow, but it could be slow or almost absent, TIMI 1, TIMI 0, absent flow. So that legend describes all of that information. But that information might be too much for most of our patients.
That's true.
Truthfully. So we nonetheless still supply that information as part of the diagram. On the right-hand side, you see a bullet. It looks like a dartboard. And imagine that bullet and number 17 being the apex of the heart. So you're actually looking at the heart end on. So 17 right here is the middle of the heart, and then we look at the heart in bullseyes,
Okay.
or little concentric circles going from apex to base. It's similar to what they do in nuclear medicine, but this diagram will be colored in depending on where the blockages are to show where there could be ischemia.
Okay.
So the more colored in that bullseye, the more ischemia there is. So that's
And
another way.
I think that might be a nice way to explain it to the patient, that, you know, maybe phrase it in a more positive fashion, as you don't have as much color here, hence you do not have as much ischemic burden.
And it really will help you show immediately a quick snapshot. You look at that circle, if you see a lot of color, you know that patient has a lot of ischemia,
Okay.
there's some issues, and they will likely have to benefit from revascularization or some sort of intervention. So it is a snapshot, it is the quickest way of looking to see how much danger your patient may be in, but yet another representation of the overall coronary tree. Another big change in this diagram is that you'll find the orientation is different. So if I were holding a heart here and I was showing you the heart, this being the left anterior descending artery running down between the right and left ventricles, in this orientation, this diagram, the LAD is running from my right and your right down to your left. That is the orientation in today's diagram. It's different from our previous diagrams,
Yes.
where it was more like this.
Exactly.
And so the orientation visually will be a bit disconcerting to our physicians and colleagues and nurses around the province when they first see this diagram, but they'll get quite used to it.
Exactly, okay.
And of course, all of these arteries are labeled so that you still know which
Yes.
they are. As long as you can identify where it says LAD, you know that that's the lesion in that particular artery. So at the very bottom of the diagrams, we have a little comment box.
Okay.
Depending on whether it's just a diagnostic film or an angioplasty film, you'll have different commentary.
Okay.
So typically that's where we're going to include some of our relevant hemodynamics, things like left ventricular ejection fraction or end diastolic pressure. We'll include hemodynamics like right atrial pressures or pulmonary pressures, and we'll have some general notation about what we saw.
Now, this gentleman here, or patient, I see he has an ejection fraction of 32%. What would I tell the patient about his left ventricular function with a numeric value of 32%?
So remembering that when we calculate our ejection fraction, what we're looking at is basically how filled the ventricle is in diastole compared to in systole when the ventricle contracts and ejects the blood out. And we're just looking at the difference between full and empty. And obviously the higher the number, the more your ventricle is contracting and the more blood you're ejecting each time. Normal can be anywhere really from 50% and up. You don't ever contract and eject all the blood in your ventricle. So no one has an ejection fraction of 100. In fact, numbers over 80 are actually abnormal too.
Okay.
That means that your ventricle is hypercontractile or maybe hypertrophied. So a number between 50 and 80 is generally normal. What's more important than that number necessarily is to also look and see what's written here, for instance, anterolateral akinesis. That indicates which walls of the ventricle are working and which aren't. So the number gives you a general gestalt of how well the ventricle is working, but more important to healthcare professionals is which walls are working, because that then correlates to the arteries, and that tells you how important the artery blockages are, which should be fixed. A patient often is concerned if that number is less than 50.
Yes.
Okay. But there are a lot of things that can affect what that number is. For instance, if you've just had a heart attack, that number may be, let's say 40%, but you will have healing, you will have recovery, and that number may go up. Other reasons why that number could be somewhat incorrect, sometimes you can have a ventriculogram when we're looking at the contraction that is abnormal or is not perfect because of extra heartbeats or atrial fibrillation or irregular heartbeats. When that occurs, we sometimes don't get an accurate ejection fraction. So that number is important, but we shouldn't have our patients or our nursing staff focus too much on it. It's only part of the picture.
Okay. So I have seen, looking in charts, looking at echo reports, words like akinetic, hypokinetic, dyskinetic, hyperkinetic. Can you give us a quick little summary on what each of those are?
Sure. So, I mean, kinesis, referring to movement, and hypokinetic, meaning low or less movement than usual, being a ventricular wall that is less contractile, contracting less, moving less, contributing less force to overall ejection. Akinesis, meaning none.
Okay.
So the ventricular wall is completely inert. Dyskinesis is also bad as well, too. Dyskinesis means that if you, let's say, had a ventricular wall and this left anterior descending artery was occluded, this whole anterior wall was not working, dysfunctional, and the muscle was dead. Sometimes when the ventricle contracts, instead of just staying there, that ventricular wall can bulge outwards.
Oh, goodness.
And that is an extremely bad finding as well, too, because, in fact, the rest of the heart is trying to contract and eject blood out, but a lot of that force is used in pushing this dyskinetic wall outwards, and your heart is far less efficient when that occurs. So dyskinesis is quite bad. Hyperkinesis is when you have certain walls that are doing more work than usual. And you sometimes see that in an acute MI setting where the other walls are trying to keep up and compensate. Or you sometimes see that in someone with hypertrophy or hypertrophic cardiomyopathy where the whole ventricle is thicker and contracts stronger than it should. Here's another diagram where we can include all the bypass grafts. Now this starts getting a little complicated in one diagram, but we will have extra bypass grafts, vein grafts coming from the aorta going down to its target arteries, and thoracic, left internal thoracic or right internal thoracic artery grafts coming from sort of off the page, generally down usually to the left anterior descending artery. So we can include bypass grafts as well. We can show if stents are put into those bypass grafts. All of that can be found. What you won't see on this diagram is you won't see any imaging or notation about valves. Okay, so if you had aortic stenosis, you will not see that on the picture. You'll probably find that in the box. Underneath a description of what the valve looks like.
So in this gentleman here, he has an area that is colored, and you had mentioned that that is an ischemic area. So when I look at this, areas 3, 9, 15, 10, and 4 have colors in them. So where would I see that if I'm looking at the patient's heart? So I've started at the bottom, 17.
So 17 being the apex, all right? And it actually is, there's a little table next to that diagram as well. So 17 being the apex, 15 apical inferior, so the underside of the heart here. In 10 and 9 referring to the mid-inferior and the mid-infraoapical, so even further back, underside of the heart here. And what do those narrowings refer, or sorry, what does that color refer to? Well, if you take a look at the diagram, you see a significant narrowing in the posterior descending artery and the distal right coronary. This distal right coronary is a dominant vessel which supplies generally the underside of the heart through the posterior descending artery. The blockage there is going to limit blood flow to the entire underside of the heart. So when we see the intensity of the color being darker means more ischemia. And the location here, right now, just looking at the target, looking at the bullseye, I can tell all the ischemia is inferior. Then my eyes are drawn to the inferior vessels
blood supply
here. And in this particular instance, the posterior descending artery and posterolateral ventricular branches are severely stenosed. And unfortunately, the bypass is blocked as well, too. So this whole area is lacking blood.
So, Dr. Lachmedia, I've always been curious. I see, and thank you for explaining that anything greater than 40 will be recorded numerically. But what if I saw a lesion of 50% and it was more distal? Would that be clinically significant to the patient?
Well, the answer is maybe.
Okay.
And so it all depends on, well, it depends on a number of things. The percentage or the number blockage tends to be something that patients and healthcare professionals focus on because it's very easily identified. You can tell when the number's getting worse from 50 to 70. 70 sounds worse than 50.
Yeah.
It's very easy to try and interpret it that way. However, one 70% blockage is not the same as another.
Okay.
And what we've been taught in years past is that typically only blockages over 70% will actually limit blood flow, typically with exertion. Only blockages over 90% will limit blood flow when you're doing minimal exertion or at rest. So we've been taught that 70% narrowings and above should probably be fixed. However, we're now learning much more through different physiological techniques. And one of those techniques can be looking at what we call fractional flow reserve, or basically looking at the pressure gradients across blockages. What we now know is that a long 50% blockage may be just as important as a short 80% blockage. And that's because fluid dynamics and blood flow through a tube is actually significantly impacted by long, moderate blockages. And we now have techniques where we can use a special wire across that 50% blockage and demonstrate that the blood pressure diminishes across the blockage. So were we to determine that, we would annotate a 50% narrowing, and we'd show that here's the 50% narrowing. But in the box below, we would probably also indicate fractional flow reserve measurements showing an abnormal flow reserve, meaning that 50% blockage is important. So we'd annotate that part in the bottom.
Would that guide your treatment therapy?
It possibly could. So there are times where we might actually put a stent or think about doing a bypass to that type of a blockage. One of the reasons why a 70% blockage may actually not be important is because we can be fooled by what we see with our eyes. And when we're looking at an artery blockage on a TV screen, when I'm doing my diagram, we're only looking at that artery in one particular orientation. But remember, and I'm holding the aorta here, but the heart is a three-dimensional structure. And the arteries in a blockage can be very different depending on which orientation you're looking. So that certain narrowings may look like a 70% blockage in one orientation, but may not be as severe in others. So there are times where we can use the same fractional flow reserve measurements and look at what looks like a 70% blockage, but realize that in fact the blood flow is excellent going across that blockage, and we leave it alone. So there are reasons why we would leave 70 or even 80% blockage visually alone if we've done those special techniques. Ultimately, it's also looking at where the blockage is. So a blockage at the beginning of an artery, like let's say the left main, or the very proximal left anterior descending artery, is more important than a blockage at the very end. So if you had a 70% blockage at the very beginning of an artery, that is actually far more important than a 100% blockage at the end. Because that 70% blockage is putting a lot of muscle in jeopardy. Whereas the blockage at the end of an artery doesn't really impact much. So where the blockage is important as well. Again, it's to reiterate, we don't want to get patients to focus too much on the numbers. And understand that it's a combination of where the blockage is, how severe it is, whether it's involved in branches or other things, and lastly, whether or not that muscle is important to that patient as an individual. For instance, you can have a severe blockage of a small diagonal branch. It can be a 90% blockage, but trying to intervene on that small artery has high risk. And it may be better to leave that severe blockage in a small artery alone so that you don't harm the patient. And we may be able to use medications to treat them just as effectively.
So down here it states in this particular report that medical therapy recommended. So we would alter whatever anti-anginal medication? Would we look at changing or adding ACE inhibitors if the patient hadn't been on it?
So we know that there's a number of things that can help impact long-term symptoms and survival in patients. And some of the most important things, when we list in 3 words medical therapy recommended, it's actually a very large number of things that we can do.
Okay.
The first things that we think of are lifestyle. And as you know, we always recommend things like cardiac rehabilitation, exercise, and diet as being the key things that will actually help a patient live longer and live better. They also include, though, medical therapy includes medications. And the medications you mentioned, ACE inhibitors, can be very important for patients. But also, our mainstays should also be something like an anti-platelet agent like aspirin, potentially or definitely an anti-cholesterol agent, usually a statin, but we have newer medications that are useful. ACE inhibitors are up there. Beta blockers can help limit symptoms. So can calcium channel blockers. So there's a list of medications that can be beneficial. And depending on the patient, whether they're diabetic, whether they have renal dysfunction, whether they have a normal ejection fraction or not, different medications become more or less important, more or less safe, more or less useful. So again, it comes down to the patient's characteristics, but medical therapy is a grab bag statement. Again, start with lifestyle changes and then move on to the medications that can help.
So, Dr. Lechmedio, there was a patient report here of a patient who was recommended for surgery, and I read his history, and he didn't have a whole lot of risk factors, so he looked like a good surgical candidate, but I wondered why he didn't receive a PCI with stenting.
Okay. So there's a lot of factors that help us decide whether or not someone is better off with stenting or surgery. And there have been a number of studies that have tried to look at this, research studies. But it's very difficult to do a research study on this particular topic because every patient is unique. And trying to create a large study that gives you direction was challenging because again, we have so many different patients put together. That being said, there were certain things that certainly helped. And our current dogma is that generally patients who are diabetic, who have low ejection fractions, or who have severe left main or proximal left anterior descending artery disease are best off with surgery.
Okay.
That being said, there are many patients that we see now with left main disease who are not good surgical candidates. And so one then has to change, one doesn't just follow the recipe and take that patient to surgery. We have to recognize that maybe they wouldn't do well with surgery because of bad lungs or bad kidneys. And then we think about stenting the patient instead. So diabetes, low ejection fraction, left main or left anterior descending artery. Those are the 3 key things that have been shown in multiple studies. We also recognize, however, that sometimes what we call bifurcation lesions, or in this instance here, this artery splits in 3, and each of those branches has severe blockages. Well, trying to place a stent into one artery is tricky enough, but when the artery splits into 3 and each of those branches has blockages, we don't have stents that split in 3. And so this would be a patient, for anatomic reasons, would be better off with surgery simply because a stent would be very high risk. And we might be able to fix one branch, but we'd be sacrificing others.
And that would be a big piece of myocardium that you put at risk.
Right. And so if we fix one artery and leave others severely blocked, we may not have done any good to our patient. So very individualized. We do try and look at those things, diabetes, low ejection fraction, left main disease, but again, it is in the context of the patient's situation. You'll sometimes see something called a syntax score, which is a score that is actually automatically generated from this program that gives us an idea. It interprets the number of blockages, where they are, whether they're bifurcations, whether they're calcified, interprets all of that, spits out a number that tells us whether or not we should think about surgery preferentially or angioplasty. But again, it's a guide.
Yeah.
It's not an absolute recipe. It's a guide, and we look at that number. We still eventually have to look at the patient and their situation first.
Okay. And I notice that this gentleman has an ejection fraction of 72%. So if he were to have surgery, I would suspect that would enhance his chances of doing well with a higher numeric value to his ejection fraction. Is that generally the case?
That is generally the case. And the higher your ejection fraction prior to a surgery, the more likely you are to actually make it through the surgery and do well following the surgery and be fully active afterwards.
Okay.
The lower your ejection fraction, the tougher it is to get through a surgery, and you may still be impacted by your low ejection fraction after the surgery as well too. So the ejection fraction is one of the important characteristics determining whether or not someone can go to a surgery or not, but it isn't the only one. And without a doubt though, higher numbers are better.
Okay. And sorry, I have one more question.
Yep.
When we look at end diastolic volume, so how full our ventricle is at end diastole, this gentleman has a numeric value of 18. So what could we anticipate as a normal number, and when would we get concerned with regard to how high it can or would go?
As a general rule, what this pressure represents is the pressure in the ventricle when it is relaxed. So in diastole, and not at the end of diastole when the ventricle is filled, both from passive filling and then from atrial contraction. So it is just about ready to contract. Okay, so just at that moment before it contracts. The higher the number, the higher the pressure in the ventricle. That can represent some abnormal situations. So numbers typically over 20 correlate with heart failure to a degree like pulmonary edema. A normal left ventricular end diastolic pressure is usually below 10. When someone has a heart attack and you have muscle that is dysfunctional, you can develop an elevated EDP, and that leads you to heart failure.
Okay.
Also, people that are chronically hypertensive or have renal dysfunction can have ventricles that are stiff or don't relax as well. And while their ventricles may contract nicely, they don't relax well, and your end diastolic pressure can rise.
Okay.
So if your numbers, again, are in the 18 to 20 range, you are approaching heart failure.
Okay.
If your numbers are over 20, you likely are in heart failure, and you likely are on diuretics. If you're not on diuretics today, you may benefit from being on them in the future.
Okay.
And if you are on diuretics and your EDP is still over 20, you may need to be on more diuretics.
Okay.
So it's a very good clue in the cath lab of how healthy a patient is,
Okay.
say during a heart attack, and it gives us an idea of whether or not they may develop complications in the
Okay.
near future. So if you're a nurse on the floor and your patient comes back following an angioplasty and they're having trouble breathing and they're saturating low and it's 88% and you put some oxygen on them, you take a look at this diagram and you see that the LV-EDP is 24, you have a solid clue that this person may be in heart failure and they may benefit from diuretic. It's different than if your patient comes back to the floor, they're short of breath, but their EDP is 10.
Okay.
Well, the diuretic's not going to change anything. So you have to think in other directions.
Yeah.
So it definitely helps lead your diagnosis on the floor.
Oh, that's wonderful. Well, thank you very much. I really appreciate this. I will share it with my colleagues, and thank you for your time.
Oh, you're very welcome.